In this video, we describe how to dissect the female pelvic organs. This work was created by Dr. Carlos Andres Suarez-Quian and Dr. Joel Walensky. Dr. Suarez-Quian is the narrator of this video. The female pelvic viscera are critical for the conception and development of human embryos into newborns. Let's start the dissection of the female pelvic viscera. The pelvic cavity is relatively small compared to the previous body cavities we have dissected. Ideally, we bisect the body in the sagittal plane in order to facilitate the dissection. Here, we see the typical cadaver after evisceration and prior to dissection of the perineum. We can identify structures that should be easily recognizable to you: the reflected rectus abdominis, the iliacus muscle, the aorta and IVC, the uterus, and the bladder. Now palpate the iliac crest. Using a scalpel, cut just above the iliac crest on both sides, all the way through the skin of the back. In the midline, because you will need to saw through bone, you will use a bone saw to cut the body in half. After bisecting the body, focus on the pelvic structures that are readily visible. Here, we have zoomed in on the pelvic cavity and labeled the following structures: the uterus, the area of the bladder covered by peritoneum, the sigmoid colon ending at the rectum, the round ligament can be observed exiting the deep inguinal ring, the fallopian or uterine tube is now labeled, and finally, the ovaries identified. Note, this ovary is disproportionately enlarged in this specimen. The procedure to bisect the cadaver in the sagittal plane is demonstrated in this image using a different specimen. We again note the uterus and the bladder. The sigmoid colon rectum interface is apparent. The procedure entails placing a probe into the external urethral meatus to serve as a guide for the midline. Then, to use a scalpel to cut through all the soft tissue organs in the midline. Ultimately, you will reach the bony sacrum, in which case you will need to switch to a bone saw to cut the sacrum to free up both hemipelvises. Both pelvic halves have now been reflected. Let's get oriented and label pertinent structures. The uterus is apparent, as is the bladder anteriorly. The rectum is cut open and clearly evident posterior to the uterus, leading to the anal canal. The bony sacrum helps form the posterior boundary of the pelvis, and the pubic symphysis the anterior boundary. Looking at a different specimen, again label the pertinent structures for orientation. Here we see the uterus, the bladder, the pubic symphysis, the rectum, and the sacrum. The pelvic cavity is continuous with the abdominal cavity, as we can now observe in the sagittal section. The peritoneum membrane, now labeled, is continuous with the peritoneum membrane of the abdominal cavity. We now zoom in to focus on the specific area. The first thing to notice in this zoomed version of the female pelvis is that the peritoneum drapes over the pelvic organs. Trace a cut edge of the peritoneum to verify this. But now it also becomes clear that the peritoneum forms recesses in which fluids, especially from infected viscera, may accumulate as it drapes over the organs. Let's name these recesses now. The recess in front of the uterus is called the vesicouterine pouch, whereas the one behind it is called the rectouterine pouch, or pouch of Douglas. The latter is especially clinically important because infected fluids that accumulate here can be removed via syringe inserted into the rectum or the vagina. We can also appreciate the peritoneal membrane in the zoomed version of an image we saw previously. Specifically focus on the peritoneum as it drapes over the uterus. The arrows point to the peritoneum anterior and posterior to the uterus, helping to form pouches we observed in the previous slides, and also extending to the lateral wall of the pelvis. The peritoneum enveloping the uterus in this region and extending to the lateral wall of the pelvis is known as the broad ligament. By the way, the broad ligament also drapes over the fallopian tube and gives rise to the mesentery of the tube, the mesosalpinx. We'll see this shortly. To complete the labeling in this image, we'll label the bladder and the sigmoid colon rectum interface. We can now again identify the vesicouterine pouch and the rectouterine pouch of Douglas. Let's go back to the zoom image and finish labeling some important structures to then continue making observations of relationships important to understanding the anatomy of the female pelvis. In this specimen, the labia majora and minora, components of the external genitalia, were preserved. The body of the clitoris is evident. Moving to the pelvic organs, we now label the bladder. Urine enters the cavity of the bladder from the ureters. The muscle making up the walls of the bladder is known as the detrusor muscle. Its function is to compress the bladder cavity to express urine into the urethra. The urine will travel via the short urethra to ultimately be excreted via the external urethral meatus. Pelvic splanchnic parasympathetic nerves innervate the detrusor muscle. Posterior to the urethra is the vaginal canal. Superiorly, the vagina ends at the cervix, and its opening is the external vaginal os. As is apparent here, this orifice and the external urethral meatus are located very close to each other within the female vestibule, and that is why urinary tract infections may occur after sexual intercourse and why voiding after sex is recommended. If we now zoom in just a bit more and focus our attention on the rectum and leave some labeled structures for orientation, we can discern what appears to be a line separating the rectum from the anal canal. This is the pectinate line. You might even be able to discern some anal columns below this line. What is important to know about this line is that the tissue below this line is derived from the ectoderm. Hence, it is served by somatic nerves, and injuries to this area, for example a hemorrhoid, will be painful. Above this line, a hemorrhoid will most likely be painless, albeit not of insignificance. Hemorrhoids above this line are likely indications of liver disease and secondary to portal hypertension. Let's move on now to the vagina and uterus in another individual shown in the image. And now we zoom in to focus on the structures of interest. The first thing we notice is that this is a retroverted uterus. That is, the uterus is not tilted anteriorly, just behind the bladder as is commonly found and indicated by the yellow arrows. Instead, the uterus is tilted posteriorly, now indicated by the blue arrow. In the previous specimen, the uterus was tilting anteriorly, the more common configuration. However, please note that having a retroverted uterus doesn't usually affect the viability of a pregnancy. A retroverted uterus may create more pressure on your bladder during the first trimester. That may cause either increased incontinence or difficulty urinating. It can also cause back pain for some women. The superior aspect of the vagina latches onto the very muscular cervix. Because this arrangement results in the cervix projecting into the vagina, there are recesses surrounding the lower cervix that are called the vaginal fornices. In a sagittal section, we can observe the anterior and posterior fornix, but there are lateral fornices as well. By the way, the singular of fornices is fornix. It is Latin for archway. The fornices are used by gynecologists to palpate the pelvic viscera. Note the important anatomical relationship between the posterior fornix and the pouch of Douglas. The close proximity is the reason that a camera can be inserted into the posterior fornix and then punched through into the pouch to examine the female pelvis using a colposcope. Unfortunately, too, it is the anatomical reason that a backroom abortion could go wrong. Instead of entering the uterus to perform a dilation and curettage, the inexperienced abortionist would enter the pouch of Douglas via the posterior fornix, likely causing bleeding and peritonitis, often resulting in the death of the woman. Let's focus again on the cervix and its opening, the external cervical os. We zoom in on the area of interest and label familiar structures: the uterus, the vagina, the cervix. Can you discern the narrow slits for the anterior and posterior fornices? Did you notice the uterus is anteverted here? Note now the indentation in the cervix. This is the opening of the cervix into the vagina and is known as the external os. The opening of the cervix into the uterus is called the internal os. Os here is being used as mouth, not bone. It is the dilation of the external os during labor that determines when a woman may start pushing. However, it is also the opening that can be used to insert an IUD through the cervix and into the uterus. Using a speculum, the vagina can be opened and the external os observed. The IUD can then be pushed through the external and internal os to prevent pregnancy. In this cadaver, an IUD was left in place. We now focus on the adnexa of the uterus, that is, the ovaries and fallopian tubes and their associated structures, in the sagittal section specimen. And to better see these structures, we zoom in on the pertinent area. Let's label the structures we're familiar with and clearly evident: pubic symphysis, bladder, uterus, and lateral wall of pelvis. But now we focus on the structures we have not seen from this angle previously. The fallopian tube, or uterine tube, emerging from the uterus is quite narrow. And what is not clear, although important to relate, is that the tube is also draped with peritoneum, actually the broad ligament, and at this point it is called the mesosalpinx. Salpinx is Greek for tube, hence we're looking at the mesentery of the uterine tube. As we continue distally with the tube becomes wider, and this part of the tube is known as the infundibulum. It is here where fertilization of the egg takes place, and then takes about 6 days for the egg to make its way to the uterus to implant. We also see the fimbriae at the end of the uterine tube that help capture the egg and bring it into the uterine tube once it is released from the ovary. Look now at the ovary. The ovary is not covered by peritoneum, although not everyone agrees on this point. Regardless, the egg is released into the peritoneal cavity. The ovary is supported at its two poles. One, the ligament of the ovary, connects the ovary to the uterus. The other pole is known as the suspensory ligament of the ovary. Ovarian vessels and nerves are found within this ligament. Finally, the mesentery of the mesosalpinx is continuous with the mesentery that helps to suspend the ovary. This mesentery is called the mesovarium. Once you're familiar with pelvic organs, including the different components of the broad ligament, the organs need to be displaced medially in order to examine the lateral walls of the pelvis. To do this, grab the peritoneum and try to gently move it from the lateral walls. Use scissor technique to dislodge any portions that will not come off the lateral walls and move the organs and peritoneum out of the way. Removal of the peritoneum exposes the lateral pelvic wall consisting of important vessels, nerves, and even the ureter. First, let's just label the structures we already know. Pubic symphysis, bladder, the uterus that is now reflected medially, and the sacrum. We now label major arteries that are visible, starting with the common iliac artery on the right. The common iliac artery will give rise to the external and internal iliac arteries, and from these, many other arteries will arise. We will focus on these later. We also see lots of veins. Finally, we see a tubular structure entering the pelvis that can be traced to the kidney. This is the ureter. But now, to explore the remaining arteries, we need to remove as many of the veins as possible using scissor technique. Remember, for the most part, if we know the arteries, we know the veins. And in a dissection, the veins tend to be in the way, so we must remove them. After removing the veins, we can more clearly identify the arteries and even begin to see some of the nerves. As always, let's just identify some structures we have seen before: the reflected uterus, the common iliac, external and internal iliac arteries. Now, we can start labeling the remaining arteries, and although it might seem complicated at first blush, in reality, the naming of the arteries in the pelvis is quite straightforward. They're named for where they go or the organs they supply. Given the starting point, we begin the labeling. From the internal iliac, the umbilical artery emerges. That ultimately becomes the obliterated umbilical. When we studied the abdominal wall, this was equivalent to the medial umbilical ligament. Before becoming the ligament, however, the umbilical artery will give rise to vessels that feed the bladder. These are the superior vesicular arteries, one of which is visible. A straight-looking artery can now be detected, the obturator artery. Just above it is the obturator nerve. Although this is the usual path for this artery, there are important variations with significant clinical implications, especially now that surgical procedures are available to treat bladder prolapse. We now see an artery heading to the uterus, and not surprisingly, it is called the uterine artery. Note the ureter just posterior to the uterine artery. Understand now why we say water under the bridge. This relationship is the reason the ureter is at risk during a hysterectomy. While tying off the arteries, the ureter may be inadvertently cut too. Observe now the arteries indicated with a question mark. Why is this? I could probably guess to their identity and point to the vaginal, internal pudendal, middle, and inferior rectal, but it would only be a guess. In the pelvis, you confirm the identity of an artery by following it to its termination. Only then can one be certain of defining a particular artery. The last artery that one can identify here is the superior gluteal artery. The reason for this is that it is in the classic location between the lumbosacral trunk and S1. Having worked so hard to identify the arteries, wait, I'm only the messenger, we need to use scissor technique to displace them so that we can continue our dissection of the lateral pelvic wall. In this image, all vessels were completely removed. However, you do not need to be this drastic in your dissection. If you cut the common iliac artery and reflect it gently, it is possible to leave many of the arteries you dissected behind and confirm their identity. But here, we have a clear image of the sacral plexus and corresponding muscles. Because I have zoomed in on the image to clearly see the nerves, it may be somewhat disorienting at first. Let me label the psoas major and the sacrum to give you some sense of orientation. We can now point to the components of the lumbosacral plexus that are prominent in the image, the lumbosacral trunk and S1 to S4. In addition, the obturator nerve is evident, as well as the sympathetic trunk. Muscles that contribute to the posterior pelvic wall and floor also start to make their appearance here. For example, we can identify the piriformis, the obturator internus and its prominent fascia that gives rise to the levator ani. We will better observe these muscles in the next image. The lateral pelvic wall was stripped of almost all of its vessels and fascia to identify the origin of the pelvic floor muscles from this lateral wall. We identify the pubic symphysis, psoas major, and sacrum for orientation. We again identify the components of the lumbosacral plexus, the lumbosacral trunk, and S1 to S4. S5 is difficult to find in a gross dissection. Again, we can readily detect the obturator nerve and the sympathetic trunk. The piriformis is again apparent, but now we can recognize how prominent the obturator muscle truly is, as well as its fascia. Indeed, this fascia forms a sling known as the tendinous arch of the levator ani. The levator ani takes its origin partly from the tendinous arch. If you pursue a career in obstetrics, you will learn that the levator ani consists of various components. This now concludes this video on the female pelvis.